Socialist Telly programme this evening, where we're going to be looking with two experts from the NHS at the government's attempts to privatise our National Health Service and national treasure, and the way that they're using the pandemic in particular as an opportunity to increase and accelerate the scale and the rate at which they're doing that. So I'm delighted to welcome this evening Dr. Bob Gill, who is an NHS GP and NHS campaigner, and who has produced a very important film about the privatisation of the NHS, which we'll link to at the end of the show. And Dr. Ranjeet Brar, who is a consultant surgeon, vascular surgeon in the NHS, and as with people in any specialty at the moment, is spending a good amount of his time treating people coming into hospital with coronavirus symptoms and complications. Gentlemen, thank you very much for joining us, and welcome.
Thank you.
Thank you, Steve.
The great NHS heist, the government's assault on the NHS, which began essentially the first time that David Cameron got his foot in Downing Street and really crystallised with the 2012 Health and Social Care Act, has become almost part of the fabric of things now, that such that the normal media, for want of a better word, very rarely really touch on what's going on. And yet it is constantly being ratcheted up and accelerated by the Tories as part of their overall plan to get rid of the NHS, which they've never been fans of. And the pandemic, the classic disaster capitalism mode, essentially, where, let's find or make a crisis and we'll exploit that to push forward our own agenda. That's what the Tories are, and the right generally, are notorious for. Bob, you're on the front line on this in NHS general practice. Give us a few minutes as to your experience and what you're seeing happen, please.
Great. Well, thanks for inviting me to speak today, Steve. What I think is important for people to understand really how far we've gone down the road of privatization. It didn't start in 2010. It actually started back since Thatcher, back in the late 70s. And, my interest and my campaigning started when, after suffering the closure of one A&E department down the road and seeing my patients struggling to get admitted, there was a threat to another hospital not far away called Lewisham. And they were wanting to close the A&E and maternity services. So that's the beginning of shutting down a whole hospital. And it was at that point, it struck me as nobody was taking into consideration patient safety and providing care. There was something else going on. And that's what stimulated me to try and find out what was going on, because it didn't make sense in a democracy why a government would be acting against the interest of the population. We mustn't consider this as narrowly party political, because all three major parties have played their part over the past 4 decades. And what in effect they're doing is acting on behalf of the City of London and predominantly American corporations, who are becoming increasingly obvious if you care to look. So what was set about 4 decades ago was started off with the outsourcing of non-clinical services under the Thatcher government. And Ken Clarke brought in this idea of an internal market, the fantasy of having market discipline somehow delivering efficiency. Well, we should all know by now that is a complete lie. You just have to look at the test and trace fiasco, and before that, the Royal Liverpool Hospital with Carillion. The whole concept of bringing in private companies to run public services to gain efficiency is a tragic, very powerful myth.
I wonder, Bob, I don't want to interrupt your narrative, but just to support that point, I mean, when I remember so clearly, and it's perhaps a slightly anecdotal thing to say, but I remember so clearly when I started working in the NHS, one of the first jobs I had in surgery was at a very prestigious hospital called St. Mark's Hospital. And there was I thinking, this is the NHS. But then right on the top of St. Mark's, you find a Robert and Lisa Sainsbury wing, and they were treated there. It's a very prestigious institute. They're a gift to the NHS. They built a wing right on the top of the hospital, new wing, purely for private patients. So consultants there can do their normal medicine. They go upstairs to the top at the end of their ward round and do all their private work. And there was always the idea put forward that private medicine is a fantastic supplement to the NHS. It's going to bring more money. Yes, to treat some other people, but by bringing more money, there'll be more for everyone. And that was the general line that was peddled. And what I thought then was, this is the thin end of the wedge. It'll start out that, you have an NHS hospital with a small private wing, but before you know it, you have a privatized hospital with a small public wing. And this is exactly what we're seeing with the increasing privatization now, not just of the peripheral, but of the core services. And that was something I thought 20 years ago. But now I'm really seeing coming into effect. So sorry to interrupt your narrative, Bob. I just thought I'd add that in.
Well, before Bob jumps back in, I mean, you mentioned, Bob, that A&E closures are the front end of larger scale downgrading of hospitals, etc. And I think you mentioned Lewisham, and I think it was Dr. Louise Irvin, was it, who was involved in the campaign to save Lewisham Hospital. And I noticed just by chance today that she commented in a Twitter thread about A&E closures, that if Lewisham Hospital had lost its A&E, it would have also lost, along with that, although A&E was the headline, it would have lost around 400 of its beds, which would have been gone for the local community. And the other thing, which I think is, I'm aware of going on at the moment, is the whole St Helier Hospitals trust situation, where, that's one of the places, as I understand it, that the government is claiming is going to be one of its 40 new hospitals that they campaigned on in 2019. And yet what it really amounts to is shutting down 2 hospitals and replacing them with one amalgamated one, which not only happens to be less in capacity than the 2 that it was replacing, but also happens to be right in the middle of the wealthiest part of the area, and as far away as they can get from the poor people who are more likely to need the health interventions. Yeah.
So, and all the time they were somehow convincing us that the NHS would be better with smaller and smaller capacity. So we've lost 40,000 beds since the financial crash in 2008, 40,000. We've got the lowest bed capacity in Europe. And no wonder the NHS was close to collapse even before the pandemic. So you have the outsourcing, you have a change in leadership. So you have a huge bloated management which controls the running of the NHS. This is not clinician-led. The clinicians are bound by their contracts, have to do as they're told. That professional autonomy is shrinking by the day. And the way they've managed to get away with selling off hospitals is by saddling the NHS estate with odious debt through private finance initiative. So, and this debt has been a very clever wheeze, because over time it increases in liability. PFI payments are protected, so the NHS Trust, in order to balance its books, has to flog off the land. This is no accident. And one of the things I want people to get across from this discussion is none of this is an accident. That is the one take-home message, that this is very cleverly thought out. In fact, the documents are there. In 1988, Oliver Letwin and John Redwood, formerly of the privatization unit of a major bank, before they became MPs, wrote their key plan for the NHS called Britain's Biggest Enterprise. And they set out in that how they're going to break it up and strip the assets. And one of the assets, of course, is the land and the buildings. So we get into 2012, which is a major step forward. Again, there was the austerity narrative after the banking crash. We were told to accept 20 billion of cuts, and there were significant redundancies handed out to staff. And that's when really services started to decline quite rapidly. So very gradually, more and more of hospital provision no longer existed. Follow-ups were reduced. So if you were under a clinic, they would look for reasons to discharge you and dump you back at the door of the GP, and then necessitate another referral, which was a way to get their income. So you had lots of inappropriate, perverse incentives not to run the health system as a rational system. Now, on top of the Health and Social Care Act, what also happened was the total decimation of the public health infrastructure. They sold off the labs. They broke down the local public health systems that were in place that served the nation very well for decades. So that was decimated. And, we're hearing about the nurses' pay settlement, but the clinical staff, and in terms of their terms and conditions, we've had 15 to 20% real terms pay cut since 2010. But in 2016, I want to draw people's attention to the junior doctors dispute. Now, this was a chance when newly politicized medics were realizing, look, if our pay and our contract is so damaged as it was proposed, people aren't going to hang around in the NHS. People are going to leave in droves. And they were right. But the take-home message for me, because I was quite active in that campaign, and the disappointing part of it was how our union, the British Medical Association, refused to link the attack on terms and conditions to the privatization, and in the end ended up sabotaging the industrial action.
That's absolutely right.
The nurses' unions kept quiet. This was a time for the nurses and the doctors to get together and say to the government, one step forward on this trajectory, no more. We've had enough.
And this is very
opportunity that was squandered by the unions.
This is very close to my own heart as well, Bob. At that time, I was a junior doctor. I was a registrar, just reaching the end of my training. I was involved in that dispute. It was a time when I've seen a huge upswell in political consciousness, really, for want of a better word. Jeremy Hunt, I said he did very little for the medical profession, but what he gave to the junior doctors was a political consciousness of just how the NHS was being used and fattened up for privatization. 26 was a crucial year for them. As you say, that was a dispute sabotaged, not for the first time, by our own union, the BMA. The BMA, don't forget, is a very conservative professional body whose top leadership regularly become lords and ladies and make themselves, into, they make a nest for themselves within the political establishment. They do so by their connections with the large establishment parties, Labour, Liberal and Conservative. And therefore, the top leadership is not interested in waging a struggle against the prevailing political status quo. And it's not for the first time. That year, 2016, of course, was the same year that they were running Operation Cygnus. Operation Cygnus, which still hasn't been released, despite Musa Qureshi of his organization. What is it again, Bob? 54? I
think it's the Cygnus report.
Okay, yeah, but I forget the name of his organization, but he's taken the government to court in order to get this report published. But it was that report which basically war-gamed or staged a rehearsal for a pandemic. A pandemic which they modeled on flu, but nevertheless was a pandemic in which they predicted there'd be an increased demand on the NHS. And what they very rapidly found, in the words that we know were the words of the report, that the NHS would fall over in the event of a major pandemic. It would fall over because of reduced bed capacity, reduced staffing, and insufficient PPE. Those were the three things that we know the Cygnus report came up with. And so what was done then to prepare for the eventuality of a pandemic? Well, we know that nothing was done. And at a certain level, there absolutely must have been a political reflection upon this report, because the government at the time, the Conservative government at that time, knew very well the direction in which they were traveling of repeatedly reducing the bed base. Bob said we've lost 40,000 beds since the financial crisis. But if you look at the beginning of this process, since the end of the 1980s, our bed base has gone from 240,000 acute beds to about 120,000 acute beds. So we've halved the bed base of the National Health Service over the last 30 to 40 years. And they must have realized that this was an irreversible direction of travel, but precisely in order to make the NHS had, institutionalized a low capacity, so insufficient capacity to meet the health needs of the population, because then on the basis of that, when a crisis happens, you can further push radical solutions, as we are seeing now, a radical solution I'm sure we'll come to, which is not new actually to anyone who's been involved with this process, but what has been intended for some time. But suddenly Matt Hancock has stood up and said we need to reorganize the NHS, we need integrated care models, We need to solve the problem of the waiting list, which is not just the pandemic, but a reduction, a deliberate reduction, systematic reduction in capacity over decades. And so that could be used to further push the process of privatization. So absolutely, this question of reduced capacity and designed under capacity in order to further the agenda is something we've seen throughout the pandemic, but actually for many years before.
Yes, I think there's, the problem I hear a lot of health campaigners have is that they tend to, and we touched on this in the chat before the program, they'll accuse the government of incompetence, not of design. But the fact is, the evidence is there that a lot of it is design. And the flat fact of the matter is, if the Tories can't find a crisis and exploit that, sometimes they'll either make one happen or inflict one, or they'll make one up. And Squawk Box cut its teeth back in 2012 with the Stafford Hospital scandal, as it was termed at the time, and that was used by the government to try to advance its agenda then. But actually, what happened there was that there was a statistical anomaly happening in the hospital that made it look like more people were dying than should have done. And the root cause of that was the fact that the hospital tried to cut costs, and therefore decided that it was going to get rid of its clinical coders, its trained clinical coders, who are, for anybody who's not aware, if somebody comes into hospital, essentially they get coded into the system with a list of the things that are wrong with them when they come in. And if you miss off the things that are wrong with them, then and then they die, that looks worse for the hospital than if they were seriously ill and properly coded into the system. So if you go in with a ingrown toenail and you die in a hospital, it doesn't look good. But if you go in and you've got 10 different illnesses, comorbidities going on with that, and any one of those could kill you at any time, and you happen to die in the hospital while you're getting treated for your ingrown toenail, it won't make the hospital look bad. But if you forget to put those codes in, or you don't pay the people to put them in, then one, it made the hospital's death statistics look much worse than they should have been. But also, it cost the hospital a fortune, because people get paid. Hospitals get paid according to the severity of the illness of the people that they're treating. So the crisis became worse, and of course the Tories were all over that then, trying to exploit this, and still do to this day in Parliament sometimes, to try to claim this Stafford Hospital scandal that was largely a mirage that was caused by some dodgy statistics. And the official reports actually said that as well in the end, and admitted it. But the media and the government is still using that as if the reality wasn't the reality. So the disaster management, disaster creation in order to exploit that to drive forward an agenda is a common factor in a lot of areas, but especially in the NHS.
We've seen, so Bob wants to say something, but we've seen also, not just even in the lean years, but even in the fat years, even at the time when we thought that there was massive investment going into the NHS at the beginning of the Blair years, was particularly the time when, in fact, investment came, and this is the way in which the NHS was saddled with so much of its debt. So Blair, Dobson, Milburn were absolutely key in saddling tens of billions of debt. So I think actually only 12 or 13 billion was drawn in from the private sector to finance PFI hospitals, but that had to be repaid back eightfold. So you're talking about 92, 93 billion, and as a repayment, you can, if you and I buy a house and we have to pay back £2 for every pound that we borrow, we feel it's a great injustice. But if you have to pay back 8 times, and then at the end of that you don't own the house, you have to give the house back or buy it again, those, you can imagine that what we're talking about in terms of the impropriety of those contracts, which is really just giving away vast sums of public money to the banking sector. And while that was started with Major in a very small way, the real people who pushed that forward, of course, were Labour under the Blair and Brown years, and that continued even further under the Cameron years. So that debt that has to be repaid, as Bob said, is ring fence. That has to come back from, the budgets of the hospital, the annual working budget of the hospital, and that has a massive ongoing impact on the finances. And as all of the trusts have now been trustified, they're meant to act as independent businesses and have financial propriety. The fact that they're having to be saddled with these debts and find that money means that they're constantly failing, being downgraded in their overall rating, because the financial rating has equal weighting with the clinical rating. So we're developing sink hospitals, failing hospitals, hospitals which are ripe for going in and say, well, something radical needs to be done in order to save it. And there you go. Now we've got these integrated care systems, new streams of funding from the private sector, which will mold with the public sector. And that's the stage at which we're getting to, quite apart from the fact that just so many core services now are being sold off in terms of contracts and have private providers rather than NHS providers delivering the service.
Let me throw a question in there then, because I mean, you know, I keep up pretty well with what's going on in the NHS. So this all makes sense to me. I know what it's about. Your average person here in, you know, the Labour health team, whether that's the shadow health secretary or other people in the health team, are extremely, and in fact, I've never heard it happen, that this kind of narrative is brought out by opposition politicians with a specific brief, supposedly to protect the NHS. So why do you think it is that we see these Labour front benchers failing to point out what's actually going on?
Because they're all neoliberals, aren't they? They're all on board with selling out the public and handing over our assets to private companies. There was a brief period under Corbyn where we actually heard the front bench mention the P word, privatization. That's all. Although it comes out, it's not with the same conviction now. So, you know, in terms of creating a crisis, I just want to go back to what's happened to general practice. So when I started in general practice in 2003, there was a new contract which did several things. It created two types of GP, a partner GP and a salaried GP. Now that model of general practice allowed the more entrepreneurial GP partners to employ several salaried GPs and basically never see a patient again. So there were built-in incentives within the NHS for GPs. They had to, in order to maximize their income, they had to see patients. And the targets and the incentives were aligned so that what was good for the doctor was good for the patient. In 2003-04, they broke those incentives. So the more entrepreneurial GPs could exploit other doctors. And what also happened in 2003 was the outsourcing of out-of-hours general practice to what was first NHS Direct and then became 111. Now all these contracts are tendered out to the private sector. So you have a two-tier GP service. You have a mushrooming bureaucracy. You have more and more people sucking data out of the system. We probably won't have time to talk about data, but this is another honeypot for the corporations, patient data. And we've reached a situation whereby GPs now have been conditioned to chase targets rather than treat their patient. The care of the patients the continuity has more or less been abandoned unless you make a determined effort to hold on to it, as few practices have. And the lockdown has been an opportunity for the government-backed shutting of the front door. So patient access, I kept my doors open throughout the pandemic and did not block access. But patients tell me their relatives and friends have had a horrendous time accessing their GPs. Now, who does that suit? GPs have inadvertently jeopardized and tarnished that relationship that has built up over generations in trusting that your local doctor will always be there and be your advocate. So they've diluted continuity, they've devalued that doctor-patient relationship. And going forward, we heard news of an American company called Centene, which now has acquired 500,000 patients on their books by buying out these entrepreneurial GPs who profited from merging failing practices. Failing practices, why were they failing? Because their finances have been rejigged and the smaller practice cannot cope with the burden of bureaucracy and providing care. So it's all been engineered in terms of a crisis, and you will face a an exodus of experienced doctors who've up to here in terms of change after change after change. And
engineered on that, Bob, is the right word, I think, because it's
exactly.
been designed to get GPs practices ready for the point where American companies particularly, but I'm sure not exclusively, would be interested in hoovering them up because they could make a profit out of it. And that's that was the blueprint way back that wasn't, of course, publicized at the time, but now we're seeing it come to fruition.
And when we hear the word integration of care, what they're really meaning is integrating public service budgets, the social care budget, the health budget, pooling it all together for up to 1 million people, and then handing control of that budget to the insurance industry. The end game. And that's why we have in charge of the NHS an expert in this, a man called Simon Stevens, formerly of United Health, America's biggest private insurer. So he's the ideal man for the job. And that's the situation we're in at the moment in terms of general practice.
Now, Nico, one of the other NHS activists we've had on the show before, he goes into considerable detail at about the way that the incentives work. They're not perverse from the company's point of view. That's clear. But there are incentives getting built into the system and already built in for doctors, for the whole health system, not to treat people, and they'll actually make more money if they don't treat people, and therefore have plenty of a carrot dangled in front of them to try to ration and divert people away from the treatment that they need. Is that something that you're familiar with on the front line there?
Yeah, so it's actually baked into the contract that the BMA heavily promoted and never took a vote of their membership back in 2019. It's called the Primary Care Network Contract. If I share my screen, I'll be able to show you exactly what Nico's referring to. This is an extract. I don't know if you can see that.
It's not come up yet.
So look. So share screen, yeah.
There we go.
So this is a paragraph from the Primary Care Network Contract. And the key thing there is shared savings scheme. Now, what this means is that there will be an incentive for general practitioners in these bigger and bigger merged practices to refer their patients, and money saved from the budget will be split amongst them. So a perverse incentive to act against the interests of your patients. And that's the model for the insurance industry.
Yes, it's funny and notable how that's always dressed up as being for the good of the patient, right?
Absolutely.
Never works in their favour. It's like you hear on these helplines sometimes where they say, for your convenience, we're putting you into a queue when we're about to keep you waiting for 45 minutes. It's, they present it as being something that's going to help.
And here again, you see that continuity, that this hasn't just come out of the blue, because the 2012 2011 Health and Social Care Act became, or rather a bill that became the 2012 Act, built that in by merging together groups of GPs who would now be the fund holders in what's called clinical commissioning groups, CCGs, which is now a very old part of our practice, but still people won't be aware. This is a relatively new change, really. So 80% of the budget of the entire NHS, the 140 billion that goes in every year, is held by CCGs. They're groups of GPs who may be excellent at seeing patients, who may be excellent in their medical field, but are not, health economists, and they're not population scientists, and they aren't people who have been traditionally people who have commissioned the entire service and the entire budget and the entire way in which the NHS is run commissioned. There used to be an entire department of the NHS that was dedicated towards planning. You can predict the number of people who will have heart attacks in Britain, in a population size of Britain, over the next year, and plan cardiac services accordingly by region and nationally, and similarly with other services, cancer services and the rest. So the dismantling of that and the giving of the budget to groups of primary care physicians who've never had that as their responsibility was setting up a system which would not be able to plan, which then had to bring in management consultancies in order to do the planning. And increasingly those management consultants have overall control of those massive budgets. And as you then merge those groups with the health insurance industry, who will say they have expertise. And in fact, part of the consultation that was recently done online, and not much trumpeted, but was taking people's opinions on whether it was a good thing to have integrated care. I mean, that sounds like a good thing. Why would you not want? You don't want disjointed care. So surely you want integrated care. But what it really was about was, allowing then governance and models of governance, to be decided by those groups who would sit on those boards, which we made up equally by, well, not equally, disproportionately by the health insurance industry, by private medical companies, and also some local NHS consultants will sit there totally unprepared for the way in which businesses are run, will be totally outgunned by the long-term strategy, short-term strategy, and procedurally by the businessmen who sit on those models, much as we've seen our schools. I mean, I was a parent governor, and I tried to sit on a governing board as they were turning it into a business model. You haven't got a clue what they're up to. You are unable to give scrutiny and governance. The teachers and parents do not control our schools, businessmen do. And similarly, it will be businessmen who control these integrated care networks, and it will be they who decide actually, and CCGs are already deciding what services can and cannot be provided, which, whether you will get this treatment or that for your diabetes, whether you have this or that treatment for your varicose veins, whether we will treat this condition at all during the NHS. So they are actively involved in rationing. And, as access becomes harder, as there's a backlog of patients, as we're encouraged more and more to see people by telephones and online, this will become an increasingly important part of the standard model of care. It won't just go away. There's an entire company called Babylon. I'm ashamed to say I know one of the medics who's involved in forming. I went to medical school with him, but they've been pushing for a long time because there'd be huge amount. You can transfer your own care from a GP to Babylon. Mm-hmm. They will receive all of the money, and they will give you just a little video consultation. You think you can get access, but it's very unsafe to have a video consultation. You can't examine. You don't get the full picture. You will not access as high quality care. And so all of these mechanisms are being used to reduce costings, because when they tried privatizing, particularly in the secondary sector, so in hospitals, and famously it was a hospital in Cambridge that they privatized, went to Circle Care. They were unable to make profit, and they were unable to make profit because actually the costs of staffing were relatively high. And so part of their ongoing program is to downskill. Instead of seen by a doctor, you'll be seen by a nurse consultant. Instead of a nurse consultant, it'll be a low-level nurse. Instead of a low-level nurse, there'll be healthcare assistants. Instead of healthcare assistants, there'll be volunteers. And this vast army of volunteers, which was a very positive thing, that the public wanted to volunteer to help out the NHS during the pandemic. They weren't actually used, but those names have been taken, and they will be used. They will be brought in to provide low-level services, of course, without any medical background whatsoever. But maybe they'll be taking blood pressure or checking temperature, but they won't pick up on warning signs. They'll be cheap, they'll be profitable, but they'll be clinically dangerous. Yes,
I mean, let's be straight about it as well. I mean, they're calling this integrated care. Integrated care was what we had before all this started, because we had one NHS with one set of kind of senior management, one set of purchasing, one set of policies, best practice shared around the whole system, as soon as it was found, because everybody was part of the same organization and talking to everybody else. What they did by creating the foundation trusts that now run most hospitals, etc., is build in fragmentation that they're now claiming they're getting rid of by having an integrated care system. But really, it's just the next step in the privatization. So, I mean, we've looked at that in the round as a general phenomenon, but obviously, we're in a very particular set of circumstances at the moment with the pandemic and everything going on around that. We've seen a government claiming to do a good job and boasting about its performance when we've had about, the official total is about 124,000, I gather now, but it's way more than that in terms of real deaths caused in the pandemic. New Zealand's seen, last I looked, I think it was 25 through the same period of time, 25 deaths. It was not unavoidable for that to happen, and yet rather than feel guilty and try to make amends, they're using what's going on to push through the same agenda that we've just been talking about, but in an even bigger and faster way. So Ranjeet, tell us, from a frontline NHS hospital point of view, how's that working out, and what are you seeing?
Well, right now we're still in a model of care where in order to try and stop people picking up the virus in the hospital. We have greatly reduced services. So our elective services are, decimated. There's many elective procedures we'd normally be offering that we're not. The Royal College of Surgeons some months ago said there are actually 10 million patients waiting for procedures. So it's the largest waiting list that we've ever had. We've seen, during this pandemic, really right at the beginning of the pandemic, the one response initially we had, you'll remember, I'm sure, that Dominic Cummings' words from a COBRA briefing early on were leaked, and he said the strategy essentially was going to be herd immunity, protect the economy, and if a few pensioners die, so be it. Now that was heavily denied and contested, but actually that's probably been essentially the response that we've seen. We've seen these periods of quite severe lockdown, but essentially every time we take the foot off the brake and let it run through the population, until vaccination came, we were essentially having a kind of punctuated herd immunity with periodic lockdown, and the hospitals were periodically overwhelmed. Now, absolutely overwhelmed in terms of our theatres were stopped, and our theatres were instead being used as intensive care units. Ventilators were being used. The theatre ventilators, which we have sometimes one in the anaesthetic room, one in the theatre, were being used as extra ITU beds and staffed as such. We were turning extra wards where we could into ventilated beds. People were being seconded from other services, from surgery, from other areas of medicine into acute medicine to try and help with the patient. So and as a result, not only just pictures of ambulances outside hospitals, which we see every year, but literally the core services were grinding to a halt. And there will be, a big toll to pay for that in terms of people who were not diagnosed in a timely fashion for many diseases, cancer diseases, cardiovascular diseases, stroke diseases, lots of pathological problems which should have received treatment will not have done. So we have seen very clearly, just as 2016 Cygnus operation showed, and we haven't seen those reports, that our hospital system was overwhelmed. So this whole mantra that we've seen, protect the NHS, stay at home, save lives, has not done that. Lots of people we know stayed at home, didn't get adequate care and died at home. We've seen a massive increase in people dying at home without receiving care.
Or in care homes. I mean, I'll just interject at that point, the fact that, when Matt Hancock was boasting about protecting the NHS and how many beds they had spare, etc., and how few people were in hospital on ventilators and so on and so on. It was deliberate government policy at that time to protect the NHS by condemning old people to die and vulnerable people to die in care homes, because it was government policy to send people back knowing that they were infected, to keep them out of the NHS if they didn't fit a certain set of criteria, and put them back in care homes that weren't equipped to barrier, nurse them, etc., infect everybody else in the home. And suddenly,
there was a directive actually,
thousands of deaths.
Directives that have come from government rather from clinicians, okay, and that's including triaging patients, because if you're faced with a wartime situation where it's quite a common thing in medicine, in trauma care, a car crash happens in the M1, and suddenly your hospital is inundated by 200 patients who need care all at once. And what do? You have to pick the patients who can have the most minor intervention that you're most likely to save lives, to prioritize their treatment, and treat as many as you can, but you have to stratify who you can treat and who you can't treat under those circumstances. We were met with that situation. Suddenly we were in the process of triaging. We can't treat everyone. Everyone who could possibly survive if they had a ventilator weren't going to make a ventilator. So actually guidelines for intensive care treatment were heavily pushed from government, and they were disseminated from our trusts downwards as to who should and shouldn't receive ventilatory care. So, the fact that over 80s and then over 70s, patients who received, who got COVID infections, who had nasty COVID pneumonia, this is severe acute respiratory distress, essentially had very low rates of survival, was used to say, GPs should go and get them to sign in advance directives that they don't want treatment. And if they come into care, well, we simply haven't got enough beds. Under that circumstance, it's not the clinician's fault that they can't instantly provide more services, but that's been baked into the system by that undercapacity. And that's what it really meant. It meant that people did not receive the care they could and shouldn't have done. And it's precisely at those times when the service was overwhelmed, which has been a great part of this pandemic, actually, in reality, contrary to the daily briefings. It meant that actually the death rate from coronavirus was higher than it needed to be. We weren't able to give the treatment that had developed first world nation, the 6th richest nation on earth, should be able to give. We weren't able to give because of levels of inequality and levels of underinvestment in the health service. And that was compounded by the fact that rather than give extra funding to the NHS to deal with the coronavirus, the reverse was done. The funding that should have come through the NHS, that should have bolstered our service, should have allowed us to build up and cope with this, actually was given behind the back of the NHS to private companies. And that was, the pathway for that was made way right at the beginning when the 2019 Corona Act was passed. That essentially gave the ability to our Health Secretary, Matt Hancock, who appears so pompously before us on so many occasions, to literally give out hundreds of millions and billions of dollars worth of contracts without scrutiny, without tendering, directly to private companies, with, of course, many of whom we've shown they have a direct improper relationship in terms of their political party, in terms of party donations, but many aren't. I mean, they've got an ethos of just generally giving all the money of the state to the private sector. You wonder what can be their possible advantage, but we've seen so many instances of people who've been in power go out of office and benefit by getting lucrative places on boards of directors, as with the gas privatization and post office privatization and all the rest of it. Or if you look at Tony Blair, of course, someone who apparently waged the war because of his deep convictions, but then going out of office has become someone who has literally hundreds of millions of pounds. So there is this direct, improper relationship between government and big business, and therefore, 45 million we think has been spent on track and trace system, or rather on the testing system, another 5-6 billion on track and trace. All of these overseen by Tory grandees, all of these going to large private firms who have made an absolute killing without necessarily providing any meaningful public intervention. We know that actually probably 90% of the people who even were tracked were unable to isolate. Many of them felt unwilling to give information to this impersonal service rather than seeing their local NHS GP, local community nurse, local public health team, who they'd be much happier to interact with, as we've seen from experience in other countries, particularly China, where they were so good at using the non-pharmaceutical measures. And then secondarily, actually, many people are unable to isolate because of the economic condition they find themselves in. There's been no support for the lowest paid, most marginalized sections of our community to weather the storm, which has been coronavirus. So when they say protect the economy, they give actually probably 250 or 300 billion pounds have been given principally to big businesses, yes, for the furlough scheme, yes, for all kinds of things, but essentially a lot of that we know has been paid out in dividends to companies. So on the one hand, the financial crash hit, hundreds of billions were given to big business. On the other hand, the response that should have been NHS was given to a host of private companies. They're too numerous to list, but they're very much in the public domain. I mean, the most egregious example perhaps is that our health secretary gave 250 million to his barman or his neighbor or barman. Every report is slightly different permutation, whether it's his barman, his neighbor who is a barman, but a publican essentially who was a friend of his and a donor to the party got 250 million for something that he had no experience of doing, which was essentially providing little test tubes, little plastic test tubes for testing kits. So this kind of largesse where huge amounts of money has gone not to the NHS who desperately need it, who actually have been starved of resources systematically, and whereas most European nations spend around 12% of their budget on healthcare, we spend around 7 or 8%. So there is a systemic under-resourcing despite the massive numbers involved. But all of that money, tens and hundreds of billions has gone to the private sector, and in an unscrutinized way, even illegal under the coronavirus legislation, which says there should be some publication or scrutiny within 30 days. That itself has not been happening. And there's just no accountability. But what we're seeing on the front line, from our point of view, is that whilst we're facing a situation of undercapacity, under-resourcing, understaffing, growing waiting lists, inability to meet demand, and negative outcomes as a result, we're seeing huge amounts of money go around the NHS into the private sector. And of course, huge amounts that goes into the NHS also basically goes inside, in one side and out the other into the private sector in so many ways, innumerable ways, not just the leasing of the buildings, not just the PFI contracts, not just the catering and the cleaning and the provision of meals, but now, if I want a CT scan at night, I'll be phoning a company maybe based in Australia, they might be based in Hemel Hempstead Industrial Estate, but I'm phoning, you know, an out-of-hours service that's got nothing to do with the hospital, that is paid for and contracted services. I'm seeing groups of clinicians say, well, there's no point anymore, you know, staying in the NHS. They're going outside the NHS, they're forming companies, selling services back to the NHS and pocketing tens of millions of pounds, whether they're radiologists or ophthalmologists. I'm seeing more and more and more examples. So, you know, it's like a feast going on at the expense of the NHS.
And the narrative around that, I think, is important to highlight as well, because the government will be giving all this money to their mates, but then boasting that that's money that's gone into the NHS. So they'll be claiming that they've increased NHS spending, and really all they've done is funnel it around the NHS straight into the bank accounts of their mates and their donors. And you know, the media will almost never challenge this narrative when they put it forward. So, you know, the average person in the street who gets their news from the 6 o'clock news bulletin on the BBC, for example, will, you know, be quite likely to think, well, actually, the government's putting a lot more money into the NHS now. And it's an absolute nonsense, but that's the picture that they're allowed to paint by the complete failure of you know, so-called mainstream journalism, which is, you know, why we run Socialist Telly, why a lot of the independent sites are doing what they do, because they're trying desperately to balance a narrative that's heavily stacked in favour of the Tories and the privatisers and the whole corrupt system. And you know, but apart from the obvious kind of direct funneling of cash which is going on at the minute and being badged as increases in spending, what else is the government doing to advance that privatisation agenda through and exploiting the pandemic in order to do it?
I think the most recent one is the 1% pay rise for nursing. So, you know, contrast that with what Ranjeet has just outlined, where the sky's the limit for the private sector, but only 1% for nurses, which you could have given the nurses a 5 to 10% pay rise and still not spend what they've wasted on the privatized test and trace system. And that has been in the budget. That's been increased from 22 billion to I believe it's 37 billion or something of that order.
Yes.
Now that would easily have covered the cost of a significant pay rise for nurses. And in France, because of the pandemic and because they realized there's a bit more pushback from the population, I believe the nurses got a 10% pay rise. So, but that's essential to keep the wage bill down before you hand over control to the private sector. So, you know, for people to be pleading with the government, oh, you've made a mistake, this is terrible, please reconsider, they need to have in mind what the business plan is. And the business plan is to keep the wage bill down as you can get it, and remove protections. So I think that's the biggest travesty. And there's still no further forward in supporting the poorest amongst us to isolate. So as the lockdown restrictions are starting to lift, we're going to see another surge, particularly of people who, if they don't go to work, even if they're ill, they won't get paid. The self-employed have been abandoned. You know, there's 2 to 3 million of those who've not received a penny in support from government. You wonder whether the decimation of small businesses, well, who does that suit? That suits the multinational corporations who will step in like Amazon to fill that gap. So the small man, the individual, the worker is the loser at every opportunity in this situation.
And we really have seen that this pandemic has hit disproportionately the poorest. Even before the pandemic hit, we had the Marmot report 10 years on, which basically showed that life expectancy for the first time in this country is, or since the Second World War, certainly is falling, particularly in the north, particularly amongst the poorest sections of the population. That health outcomes are becoming worse, and that's linked to poverty, inequality, low investment in health and social services, and poor political leadership were the things that the Marmot report picked out. And they're not avowedly socialist. They're just simply people who look at data and look at data of life and health outcomes. But we have seen in this pandemic that the very poorest sections of the population, and that meant particularly immigrant community, particularly the poorest sections of the working class, You go to areas like Barking, Haveridge, Redbridge, the kind of northeast. London has been the center of this second wave, precisely because there are people who cannot afford to isolate. If they stop working, for their very low wages, 0-hour contracts, frontline services in transport, in shops, without them continuing their work, they literally cannot support their families and their extended families living in small, cramped, crowded conditions. Multi-generational families have been disproportionately hit. And I'm afraid to say that this has also revealed a certain level of endemic racism within society where we don't necessarily also see it even within the NHS. So in the first wave, I was phoning a colleague, said, wow, we were actually asking ourselves, why do you think that the death rates are highest amongst Black and ethnic doctors? And he said to me, look, you come to the COVID ward at my hospital. I'm not going to say which hospital it was. He said that you'll see it staffed by all the Black and ethnic and Asian doctors, partly because they're locum and they just go where they're told, and partly because doctors have any tenure or seniority and are afraid, are able to distance themselves, particularly if they're in relatively senior and managerial positions, and they're more likely, less likely to be those ethnic doctors. So there's many levels at which, we've seen discrimination, principally financial, but they're, always compounded by a low level of endemic racism. It's been the poorest and most marginal sections who have been hit hardest in the pandemic. And that's not just the pandemic, it's our life, it's our economy in general. This growing level of inequality we're seeing in society is underlying all of the problems we're currently seeing. So, that actually with this financial crisis, global capital is stalking the world and finding ways to extract surplus value, extract loot, extract money from everywhere it can. And it has the state sectors of the large countries, Europe, America, very much on its mind. TTIP was about that. Trans-Pacific Partnership was about that. Those were deals which Trump scrapped when he came in, saying that they weren't enough in America's favor. But these kind of things we're seeing built into the proposals for care, that not only will CCGs have to contract out their services to the private sector increasingly, but if the private sector companies don't get the services they want, they'll be able to sue the NHS to say we should have got the service. And in fact, we know that Richard Branson, when he was involved in the paediatric service contract in Cambridge, again, actually sued the NHS for an undisclosed amount because he didn't get the service that he wanted. So he's taking perhaps tens of millions of pounds from the NHS for doing nothing, and it's not the first time that we've seen that. So this is increasingly what we're seeing in terms of the 1% pay cut, the pay rise, which is in reality a pay cut. I absolutely agree with Bob. There's a fundamental disconnect between the people on the front line who've been providing the services and those who are running the services. It was very interesting to see right at the beginning of the pandemic, Boris Johnson actually realizing the extent to which control has been given away from government to Sir Simon Stevens, to NHS England, and that some of the things they wanted to do, which were actually give away contracts to the private sector, they were not able to do. And again, part of the reorganization will actually keep the private sector involved, but it will get rid of any pretense at scrutiny over the contracting. So they'll be able to carry on this process of just giving away vast sums to the private sector without scrutiny, but this will be generalized and spread throughout the NHS. So again, something that we thought was just an emergency measure will be introduced as a general practice, which will hasten the privatization rather than retard it. So rather than save the NHS as the constant slogan of the government, they really have been relentlessly and constantly attacking the NHS throughout this pandemic.
I think that's a good note as we come to the end of the program to round off on. But Bob, I'm going to let you say a quick word about your film and point out where people can find that, because I'm sure people hearing this will want to inform themselves better about what's really going on. And you produced a film that goes into that in some detail.
Yeah, so the film, The Great NHS Heist, gives the background to how the NHS over the last 4 decades ended up where it is, and also paints quite clearly the future direction, which is US corporate takeover, specifically the private insurance industry from America. And
fantastic. We'll put a link up to that at the end of the show as well, so people can see it. Yeah. And we'll put are you both on Twitter, for example? Can people follow you if they want to?
Yeah,
Yep.
Twitter. My Twitter handle is Rango, RANGO Rango 1917, RANGO 1917 at Rango 1917, isn't it? Twitter handle,
Yes.
isn't it? At Rango 1917. I wonder if you'd be able to just put a little plug for something that I think is a very good idea, which is there's a corona tax.org, which is a campaign asking for a tax to be placed on the most wealthy individuals, a 5% tax on the most wealthy individuals in society, rather than, as we've seen in the latest budget, actually what they're going to do is, yes, the higher incomes, but they're going to distribute this huge amount of spending, this huge largesse that has gone to the private sector. They will have to repay. You know, there's an idea that they don't have to repay it, but they will have to repay it. They'll repay it by raising the tax in a broad section of workers. Whereas actually, and they've talked about raising corporation tax, but that's not going to come for 2-3 years. And we'll see whether it actually ever materializes at all. So there's a plan to raise that money by raising tax actually on quite a broad section of workers. We're saying actually, if you taxed, a handful of individuals, who have net worth over 10 million, you could happily raise tens of billions of pounds, and in that way start to give funding back into the NHS, grant these higher pay rises to frontline workers, whether it's teachers, nurses, healthcare assistants, or indeed doctors. And I think that's a good campaign that I'd ask you to support. I think it's www.coronatax.org. If we could put a plug for that, I'd be really grateful.
Superb. Gentlemen, thank you ever so much for your time. It's been a fascinating discussion. And no doubt it won't be too long before we'll be back in touch with you to come and tell us some more about it. Thank you, everybody who's watched as well. I hope you found it as interesting as I have. Take care.